Good afternoon all. We'll be moving to the second session of the Training the Trainers Fellowship Program in Cataract and Glaucoma. I'm Dr. Tamilarsi. I'll be moderating the session. Dr. Harshul will be joining me. I invite the expert panels, Dr. Surender Singh, Dr. Shushmita Kaushik, Dr. Chandrima Paul, Dr. Suhas Haldipukar, Dr. Gaurav Latura, Dr. Mohan Rajan, Dr. B. Panneerselvam sir, Dr. Virendra Agarwal, Dr. Naren Shetty, and Dr. Krishna Prasad. I now invite my first speaker, Dr. Meenakshi Ma'am, Director, Academics and Senior Consultant, Department of Pediatric Ophthalmology, Shankara Nethralaya, to talk on the curriculum of teaching schedule for a better scaffold. Over to you, ma'am.
Thank you, Dr. Tamilarsi. Good afternoon, everybody. I am not with Shankara Nethralaya anymore, but physically, I'm emotionally still there. All right. So, going back to the topic, that was the curriculum of teaching schedule for a better scaffold. So I couldn't right off the bat understand what exactly it meant. So I thought there is many ways to look at it. But I thought, okay, let us deconstruct. Anything that we don't really understand right off, then we try to break it down. So I thought we'll start off with, do you really need a curriculum to run a fellowship? Can you not just have that person hang around in the room, watch you closely, speak and do your surgery and do all those magical things and just learn? So how does a curriculum add value to your training program? So an effective curriculum provides the teachers, students, institution leaders, and community stakeholders, because your program, your training program may be sponsored by an NGO or some donors. It gives everyone a measurable plan and structure for delivering a quality education. So everybody is on the same page. That's what how a curriculum adds value. What else does a curriculum do? It identifies learning outcomes, standards, and core competencies to be demonstrated by the trainee before advancing to the next level. I have one of the super trainers, Dr. Sripriya from Shankara Nethralaya. And I remember always you have to do an SICS Viva before you can even start thinking about doing an SICS. Am I right? And so on and so forth. So that is what a curriculum does. It defines the core competencies to be demonstrated. So, but what is your role as a teacher in designing the curriculum? Well, first, developing it, implementing it, then periodically assessing the curriculum to see if it's doing what it is meant to do, and if required, modify the curriculum. That's fine. Curriculum is on paper, or these days it is on the web, on the net. How does it become alive? How do you take it to your training program? Well, we can look at the curriculum as in two ways: the delivery mode of the curriculum and the teaching approach that you may want to adopt. What do we mean by delivery mode? Face-to-face, which has been traditional, the most common way of delivering your training is face-to-face. But with COVID, we all have also learned that it can and perhaps very well be online and synchronous, where the curriculum is your lecture or whatever is being delivered, and the student is at the other end, tuned in and listening. Or it could be asynchronous, where everything is loaded and then the student, the fellow, looks at it on their own, at their own time. Or it could be a hybrid, a bit of online and a bit of face-to-face, which is wonderful. Or blended synchronous, similar to this. And we won't talk about high flex, which is not appropriate for our situations. Okay, so those are the several ways in which you can deliver the curriculum. What about the teaching approach? The teaching approach traditionally very often has been teacher-centered, but it can very well be student-centered as well. So what do you mean by teacher-centered? That is, the instructor stands there, provides information to the student. Whereas a student-centered teaching approach, the student builds understanding with guidance of the instructor. So the theoretical support in the teacher-centered is called behaviorism, where the learning consists of inputs delivered to the students and outputs such as performances. You want to see whether what you taught they've understood. So you have a bunch of exams, essays, or presentations by the student, and then you tick off and say, yeah, I think they've learned it. Whereas constructivism is student builds understanding using prior knowledge and new experiences. So you as a teacher first gauge what the student knows, and then you add to it. So the teacher's role in the teacher-centered way of teaching is to just deliver information, measure outcomes. Whereas in the student-centered, it's to provide experiences and guide meaning-making. So in the first one, it's passive learning. They just sit there and take in information. Whereas when it's student-centered, it is active learning. And then you ensure that understanding happens. So what are the ways in which we do it traditionally? Yeah, direct instruction. That is it. Modeling, where you're the role model. Explanation, elaboration, lecture, demonstration. Thinking aloud through the processes. As perhaps I'm sitting there and doing a cover test on a squint patient, and I just keep talking the whole time. So that is one way. And then at the end of it, you recap or summarize. Whereas in the student-centered way to deliver something, you do interactive lectures, asking questions, guiding the student thinking. Maybe you have them construct mind maps, prompting and cueing, building a scaffold, thinking collaboratively with their students, and constantly have formative assessment to make sure that they are on the right track. So the assessment, the role eventually in a teacher-centered program is to just sort learners: good learner, poor learner, bad learner, average learner. Whereas here, it is to guide the learner. So when we actually talk of, since this is a session about cataract and glaucoma fellowships, so when you look at the International Council of Ophthalmology, they have come up with a bunch of curricula for several subspecialties, and one of which is a subspecialty training in glaucoma. And so if you do open this, and I hope it opens, and it's a wonderfully developed curriculum. I was part of the pediatric ophthalmology curriculum development, and this defines just everything. It defines the settings, it defines the role of the fellowship program director, how should a faculty be, how exactly should the whole, what facilities and resources should be available. So it is very dynamic. It's not just a list of topics that need to be covered. It really is the setting in which the whole program needs to occur. So that is the ICO curriculum. So going back to the presentation, another excellent curriculum to look at is the Iowa glaucoma curriculum. I'm very proud because I did my fellowship in pediatric ophthalmology from Iowa. And Dr. Allward was there when I was a fellow. This is an excellent curriculum, and you will find that in that, all the topics have been divided into subtopics. The entire gamut of topics of glaucoma are covered, and each one is covered as a video lecture given by Dr. Lee Allward. For instance, if you take something like developmental glaucomas, and there you can see not only is the topic covered, but there's also supplementary material given for each one of these. And so that's what each one looks like. There's an excellent lecture. For example, this is for about 18 minutes, and it covers primary congenital glaucoma. I was looking at curricula in Indian settings, and I came across this very exhaustive curriculum from Narayan Nethralaya for the fellowship in phacoemulsification refractive surgery. And this is again, I think, mandatory because it comes under the Rajiv Gandhi University of Health Sciences. And so they require a curriculum to run a accredited program. So there is also phaco by the AIOS. Committees have been formed, curriculum has been circulated, and curricula have been finalized. I was part of the pediatric ophthalmology curriculum. So interpreting the curriculum, for example, if you say developmental glaucoma can be interpreted as a quiz, case presentation, lectures, you can moderate a session, you can have journal clubs on the topic. So that is how a curriculum comes alive. So, but the teacher's role is to share the essential articles, textbook chapters, resources from the internet, and provide his or her own videos or references. Thank you for your patient listening.
Thank you, ma'am. Just one question from my side. How often the curriculum should be refreshed, and what you advise in this COVID era, how it should have been changed? Or
as far as curriculum revision, it can be quite a tedious process, actually. So if you have accrediting bodies, they usually revise it once in 5 years, not more frequently, because it requires a lot of time and effort to see what has changed. And you need to change it across the board, not just the topics, but the way you deliver the training, how you define the faculty. Everything has to be changed. So once in 5 years would possibly be ideal. The experts could weigh in on this.
Yeah. I think it's not only time, basically, the effort required, but also because the curriculum has a cycle, because it takes, to formulate, then to implement and to assimilate that process. Right. Because if you're making changes too much, then you're actually, the process of learning gets disrupted. Right. So as you said, 5 years, but anything with 3 to 5 is a good time. So if you want to do early, 3 years, but again, that's a little too early, and most people would settle for at least 5 years. Yes, so I think you did a very nicely, summed up all the things.
Thank you.
I think that's very good. Another comment is that, you did mention different models of teaching and learning. I think over a period of time, we have already kind of, the teacher-oriented approach has been predominating in our curricula and how we implement it. But I think subconsciously, intentionally or unintentionally, we have actually moved from learner-oriented. I think the reason is that, if you go back in time when most of these curricula were developed, especially for the health sciences, then the source of knowledge was the teacher. And you actually depended on him for almost most of the knowledge. Right. Now a lot of things are available in the books, internet, and the peer. So the connectivity, the communication has become very easy. So the access to knowledge is actually very easy now, and previously that was not the case. So the access to knowledge was through the teacher. Now it is not through the teacher. Now you have independent sources of access of knowledge, but you still need the teacher to guide you to assimilate that knowledge, and also the proper implementation of the knowledge. Right. Especially in the areas where you need a skill development. So the skill development doesn't happen through just the knowledge. So you have the knowledge, you have the skills, and then only you get educated. So I think we are kind of moving into a learner oriented, in the sense that dependence on the teacher for knowledge at least is not there nowadays, but we do need skills and other traits of the education, like the behavioral traits, which are very hard to learn otherwise. So for there you need a teacher still as a role model.
Yeah, role modeling. But absolutely right, Dr. Pandav. The thing is, like you said, there's just too much information now that the student has to deal with. So I think the teacher's role now has changed to one of guidance as much as just imparting the knowledge. So they know what to study. It's very easy for students to look at shortcuts. So it's important for a teacher to become a guide as much as just a knowledge giver.
Yeah, wonderful presentation. So you said in your presentation that the Cataract and Refractive Fellowship at Narayan Nethralaya was under the Rajiv Gandhi University. So what about the other fellowships of Shankar Nethralaya and LVP and all that? Are they standardized under a university?
No, in Tamil Nadu, it's not required.
Yeah, so
this model was tried about 10 years ago, but the university, for whatever reason, insisted that the fellowships all have to be one-year fellowships. And that was not fair to certain specialities like vitreoretina. And then the paperwork became just too exhausting, where all the students had to be re-registered after the first year to continue the second year. It's just, it became a humongous amount of paperwork. But I know it's very, very common and sort of mandatory in Karnataka. But I'm not aware of other university governed fellowships the rest of India. Somebody from LVP can speak, I'm not
Yeah,
sure.
that's what I wanted to know, because
Yeah.
once you do these fellowships, you actually give your 2 years of prime time, and then say you go out, and if that fellowship actually doesn't carry a value or a university accreditation, then maybe one would be choosing one for the other.
Right.
that
The
kind of a
traditional
thing.
model in
Yeah.
India, as I understand, has been that a lot more importance is given to the institute where the training happens, rather than the banner, come under the banner of a university. As opposed to, say, the US, which is the only other one I know, is where it comes under the association. For example, the APOS is what governs all the APOS accredited fellowships. I know we are trying to do that in India. We're trying to bring all the fellowships under the banner of the All India so that there is standardization and accountability. But I don't think we're there yet. We are on the way
Yeah,
there.
we need to move on
Yeah,
for that,
yeah,
actually.
yeah.
Yeah, thank you.
I completely agree, Dr. Meenakshi. Actually, it is so important that, it doesn't matter if you are affiliated with RGHS or anything. I think a fellowship is more of, okay, what you specialized in, that's what the mindset comes, person who's employing you. The next, what they look at, they don't look at other things. First is the character. They'll see the character of the person, and then immediately the skills and the clinical knowledge. I think that is how a normal any private institute would look at, than looking at, okay, is it affiliated with RGHS or anything else? I don't think so that they go into those details. I would like to also comment, I know we don't actually document it, but this is a very, very important, is the holistic well-being of a student. That is something that we do, where every student, goes through very regular meditation classes, yoga classes. And this is so important, because we don't realize the current generation of students, they go through a lot of stress, and not just students, even any doctor consultant goes through a lot. And it's very important to show that you're with them and help them through that process. Makes a lot of a smooth sailing for a student during the course of a fellowship or training.
Can't agree more. We did introduce in Shankar as well the heartfulness trainer, because it's non-denominational, to come and talk to the incoming PGs. PGs are also, being younger and have a lot of cultural adjustments as well, coming from different parts of India. They, are very excited about the dosa on day 1 and 2, and then they only see colored rice or whatever it is, and it really affects them a lot. So, and I know my cultural adjustment when I went to PGI. So, you're right. I think meditation helps a lot, and I think that's a very good point. Thank you.
Thank you, ma'am. I invite our next speaker, Dr. Sri Priya Krishnamurthy, consultant, SN Chennai. She'll be talking on the clinical program schedule and why.
Good morning, everyone. Should I turn it on? You'll be turning the timer on. I think the previous speakers have all made quite a few of my points easy. So I'm going to cover on the clinical program schedule and why we have to have it like that during the fellowship. So I'll touch upon why we need fellowships, what they need to learn during the fellowship, and how to go about it. So any person goes through a part of examining the patient by asking history, evaluating the patient, using his theoretical knowledge to interpret it, come to a differential diagnosis, do the pertinent investigations, come to a conclusion, and then based on that, treat. So anywhere in this chain, if there is a weak link, then the treatment of the patient gets affected. So at present, our postgraduate system in many places are either from smaller centers, or they have inadequate exposure to subspecialty, or they lack theoretical knowledge or inadequate surgical exposure. There is no uniformity in the quality of the students emerging from different centers. Many centers do not have any mentoring going on, and overall the clinical acumen of the students has come down. Apart from it, in glaucoma, it's a progressive disease, so it's like a longitudinal study, whereas during our post-graduation, we come across patients and we follow them up for a short period of time. So it doesn't prepare us for a disease which is going to be of a lifelong duration. MIGS is considered the in thing, and unless we do a fellowship, we are not going to know more about it. Pediatric glaucomas and syndromic diseases are also much more, and unless we are in a tertiary center, we will not have enough exposure. Post-operative management of glaucoma surgeries is almost the secret of success, and unless we follow up the patient, we will not get to know. And this is one thing that is missing in our postgraduate program, because after the first day, it is the consultant that is following up the patient. The same applies to cataract surgery and its complications too. There are many papers suggesting how, in spite of having a planned residency program, there are lacunae in that, which is reflecting in the quality of the students coming out, and also there is very little or no incentive to implement the websites where so much of knowledge sharing is available for the candidates to study and learn by themselves. Dr. Grover has given a beautiful detailed report of all that a residency program should include, step by step, based it on the ICO system and modified it to the Indian scenario. But when Dr. Gogete and all in their study evaluated it, they found there is a lack of standardization. There is a wide range of competence of the doctors emerging after their post-graduation. When compared to the last, the 20th and the 21st century, there is what we found is that the surgical load has not changed except as far as cataract surgery is concerned, whereas all other subspecialty surgeries are still almost where they were. The only thing that has changed is the diagnostics, where there is much more increase in the use of applanation tonometry, gonioscopy, automated perimetry, etc. So we do need a fellowship. But we also have to remember, when a fellow comes in, all the fellows are not starting at the same place. Each one is at a different level in the race during the fellowship. So our entire training program has to be titrated to each one of them. So our OPD observation is one thing that they need to go through, and during that, it is not only watching us evaluate the patient, seeing the findings along with us, but they also they watch how investigations are done, what is the treatment that we advise, and also how the patient responds to the investigation and the treatment. Going through the case sheets and discussing the file with the surgeon is also essential for the person to learn. There is another secret that they are also watching. They learn the art of talking to the patients. Apart from it, we as consultants also have to remember there are a two pair of eyes watching us and learning our morals, values, ethics, our punctuality, honesty, and integrity. This, if we incorporate in our training, is going to be imbibed in them, and that, I guess, is called professionalism. So this is something that they take back with us, and we have to inculcate in them. Diagnostics is the next segment of the clinical evaluation program. So both clinical applanation tonometry, gonioscopy, etc., as well as the investigational diagnostics also have to be a part of their curriculum. Unless they can do the necessary investigations and interpret them correctly, the treatment is not going to go the way it should. After they have enough exposure, then they need to be put through an independent phase of work where they do it under guidance. That way, it helps them clarify doubts and also builds them self-confidence and skill in a safe manner. Once they have done independent work under guidance, then they can go back to the peripheral centers or the community services and implement it in their clinical practice. That way, they also gain confidence, as well as the patients also gain the skill of a trained doctor. Scrutiny of the files is very, very essential. By scrutinizing, one, the trainer comes to know whether he's maintaining the standard of eye care that he is supposed to, and also comes to know where a particular individual is lacking in his curricular level of development. Next is the most favored portion for any student, which is the surgical observation. So here, I believe that 90% of surgery is in observing surgeries. You learn different techniques, learn behavioral patterns of surgeons, learn different skill sets, and also going through the file for the patient who's undergoing surgery will teach you how and when to operate upon a patient. Wet lab definitely helps learn their skill set faster. It also gives the weaker surgeon the chance to catch up with the others in contemporaries in his batch, and also in short-term programs, it does reduce the time period that they need to learn. Virtual reality is great in that it is objective because it gives the objective score for the candidate without any interference from the trainer. The surgical hands-on is the last thing in their training segment, and this has to be under supervision because in a short period of time, the candidate has to learn his skill set. At the same time, the patient has to be safe. And whoever supervises them has to have the thing that they have to transfer the skill to this trainee. In the West, there is so much of importance given, almost equal importance given both to the primary surgeon as well as to the observation that is done. Logbooks, case discussions, and listening to lectures and participating in that also are a part of their training system. A little bit of medical statistics, there are so many websites just like this I just mentioned, also helps the candidates interpret the glaucoma journals, especially because it's full of statistics, and also helping with the publication in the institute and a little bit of paperwork builds self-confidence in the candidate, gets them to be known in the medical field when they start doing paperwork, and also breaks the monotony of too much of clinical overload. In our country, the Medical Council has detailed affiliation guidelines for awarding fellowships to a center, but there is no fixed protocol yet for certifying the candidates that are emerging after fellowships in different institutes. In the West, like Dr. Meenakshi and Dr. Grover mentioned, there are so many structured programs that are done where the faculty are also evaluated whether they are capable of conducting a fellowship under them, and also there is communication between the center and the governing body to ensure that they are delivering the goods. And the trainee also has to give a feedback about the center back to the governing body so that the quality of the candidate emerging after a fellowship is uniform across the board. So the ICU, as you all know, have so many systems both for surgery as well as for OPD, and the SIM Oscar is now available for the trabeculectomies. But what I want to highlight about the OSEX is that they give so much of importance to the history taking, to the empathy, the explanation of the clinical situation to the patient, and communication with the patient, which is, I think, a skill set that every candidate has to learn from us and incorporate in their program. Like Dr. Dave mentioned, mentoring is very important, and all this fellowship program will become successful only if there is a proper mentoring. The mentor's aim is to guide the candidate and motivate him through the program, monitor his progress because some may be lagging behind for different reasons, as Dr. Meenakshi mentioned, and also troubleshoot both his personal as well as his training related issues. A mentor, I personally feel, should be neither too senior nor too junior, but also should be very approachable and, most important, interested in teaching and training and sharing his time and space with the trainer. Evaluating the program. This is one thing that we all have to think about, because evaluation also leads to criticism, and unless we can criticize ourselves, there will not be course correction. The AIOC has a beautiful way where they have an exit survey where excellent questions are asked both about the institute as well as what training they underwent. They even check whether the faculty who are fellowship trainers are having enough adequate clinical load practicing, which they are practicing. Clinical material they have, adequate teaching they have, surgical logs, everything is given back to the center. So when if we incorporate all this into our fellowships, then we can make our fellowships very interesting. And what does the institute gain by making a fantastic fellowship? It gives a good ophthalmic care to the nation if you want to make it look good, but also it makes us get better fellows into our institute. And of course, if their fellowship is good, they are the best ambassadors for the institute. And for the fellow, it gives them catch-up time by doing a fellowship. He learns from the clinical load, and remember that subspecialty practice helps him survive in the world, and it also acts as a launch pad for their private practice. It gives them the confidence to face the world. Thank you so much.
Thank you, ma'am, for the wonderful talk. How often do you evaluate your fellows or PGs, ma'am? And if they are a slow learner, what do you do differently to enhance their performance?
Actually, we have to divide them into postgraduates, short-term fellows and long-term fellows. If it's a postgraduate, then it depends, it varies in which segment they are lacking. So if it is going to be, whether it's the thesis-related work in which they are lagging behind, or whether it is a clinical work or a surgical work. If it is a surgical work, then we put them through wet lab training. And sometimes, many times we have found that if we go and supervise, generally I do a lot of supervision for surgeries. So I take on the trainee and see what is the reason why they are lagging behind. Sometimes it's a mental block. 3, 4, 5 surgeries, they have had back-to-back complications, then they just freeze up. And then what happens is they get worse because they try to overdo every step and they run into trouble. So at that times, there have been occasions where I have told them to stop operating. It's not that they have to be pushed every time into a wet lab to get them out of it. If you think that their hand is okay and their attitude is okay and it's just that they have a mental block and they are paranoid about their surgical skill, stop them from operating. Just allow them to observe. Then one day, take them back after a month under your supervision and you'll find it's a transformed surgeon. If you feel that they have tissue handling is not okay, then definitely they have to go back to the wet lab. Until their wet lab tissue handling improves, they should not be coming back to the human eye. Making them observe surgeries, and when they observe, what you should tell them to do is watch the surgeries from outside the microscope. Many times when we watch surgeons operating, the instruments walk in beautifully into the eye. So everything goes very well. But what actually is missing is that the candidate doesn't know how to instrument. So make them watch outside the microscope, how to hold the instruments, how to introduce the instruments into the eye. So when you're doing it, if you explain that and make them watch that, you find that next time they can practice that in the wet lab, and then they find that what suturing they found difficult or whatever step they found difficult is suddenly become easy for them. So it varies on what stage they are in.
True, ma'am, but in my observation and experience, if we tell them to stop a surgery, they take it in a negative way. And how do you put it and make them understand?
Very,
Whatever
very true.
explanation
Very,
we
very
give,
true. In spite of my attempts, there have been one or two who still have they put me black marked. But most of the time,
Especially
what I do is
the short-term fellows, when they come for only about 15, 20 days or 1 month, we have short-term fellowship as well. And if you ask them to stop, they come all the way from different parts of the country, and they are all practicing ophthalmology. That's a big
Correct.
problem. So it's very difficult. It's a double-edged weapon, actually.
Very true, sir. Very true.
Yeah.
But generally, we don't do it for the short-term fellows. Short-term fellows, we push them into the wet lab. We give them intense wet lab training. And I tell them, whatever is your number, 20, 25 numbers, whatever numbers, don't worry. Even if you're behind the others, we will soon do the catch-up. So I give them, they do a wet lab for a week or something. Then when they come back, instead of one surgery, they are doing two. So at the end, when they go out, they are at par with their friends. Because if we end up taking over the surgeries every time, then they are still not going to be happy. So we might as well give this a shot. But I am talking for the long-term people. I always first tell them, okay, you do this correction, you come back. You do this correction, come back. After 3-4 attempts, if it is not working, it is also depending on whether it's their skill or it is because of multiple complications that they're having back to back. Only for those people who are having multiple complications, and when the instrument, you realize they're holding the instrument so tight, they're sitting like that, rigid like rigor mortis, then you know that they have to have a break from surgeries. If they are relaxed, and there have been people who have stereopsis issues. We have people who have instrumented above the cornea thinking they are doing capsulotomy. Those people, when we just take one look at them, we know that it is a stereopsis issue. And I've sent so many people to Dr. Meenakshi to evaluate, and then we put them through the entire orthoptics course. And those people, their eye has to be aligned before they come into the theatre. So what we do is 8 o'clock we send them and their eyes are rested to the orthoptics clinic. They finish their orthoptics, come back, and 9 o'clock is their surgery. So when we do like that, there is a sudden transformation in their surgical skill, and that is the greatest bonus that a trainee can have. When he can do something well, he gets so excited. And then it's up course.
I instruct all my PGs to first undergo refraction and orthoptics complete evaluation and then start.
Let me tell you one thing. They do all that, but there are people who manage to get an absolute 100 on all that, and then still they cannot see under the microscope. And stress also makes them accommodate so much. I have, even just last week, I had put myself in +8, which was the maximum that the side piece could reach, for me to see at least something that the student was seeing.
Okay.
That is the amount of accommodative spasm they have, and one person I dread supervising are the young myopes. They have fantastic accommodation power. So we have to be ready to.
I think one of
battle
the
them.
major issues in the training program is that the ophthalmologists or the fellows or the postgraduates, they have difficulty in using the microscope.
Very true.
I think we have training wherein for 1 week they sit under the microscope and do the XY, do the up and down,
Very
fine
true.
focus, and foot switch coordination. And the microscope, because if they don't see well, obviously they're not going to operate well.
Very
That's the main thing. So usage of the microscope, operation microscope I think is a key factor.
Absolutely.
Before I think.
Especially four-limb coordination is so difficult. You have a very
Absolutely.
valid
Yes,
point.
Yeah.
I think wet lab is very useful there because they get
Absolutely.
we get to practice everything
Yes, sir,
before.
yes, sir, correct. Yeah.
Thank you so much.
Thank you, ma'am. Thank you.
Sorry.
Our next speaker is Dr. Ashish Bajaj, consultant in Sri Sadguru Seva Sangh Trust, Mumbai. He'll be talking on cataract surgical training and beyond.
Morning to all. My topic is cataract surgery training and beyond. First of all, I'd like to thank the ARC for giving me this opportunity. So I'll be speaking about what advice you should give to your fellow or trainee once he has completed his fellowship, because during the fellowship, the trainee is mostly concentrating on the surgical aspects. There are other aspects like patient communication, patient satisfaction, and also if he's going to set up a practice, there are going to be administrative skills also which he might need to carry through. So just as Siripriya madam said that the training program, it should be in a stepwise manner. So we also have this stepwise manner program, of course, keeping in mind safety and quality, and also we monitor the progression of our candidates throughout the fellowship. So if you see that the final goal of any training is to get the basic and innate skills, and once you have that skill set, it is now time to employ that skill set for cost-effective, efficient patient care. Of course, keeping in mind what the patient needs and what the requirements are. And that also can happen through a standardization of all the surgical steps and the curriculum. So what are the options available after fellowship? Most of the times as fellows ask what I should do. Well, it depends upon individual temperament. Person-to-person variation occurs. Somebody who can take the responsibility alone, individual practice is there. Group practice is the norm these days because there are shared responsibilities and finances, and you can have time for leisure activities as well. So one of the commonest mistakes the fellows make is when he goes out, he takes up the complex cases first. Well, you should go back to the basics, I feel, because the place is new, everything is new, equipment is new. So you must do the clean cases first, where you have good visual outcomes, develop some confidence, and then go back to the more complex cases. Also, as a young surgeon, they are very enthusiastic to do surgery on every patient. So they should understand that every patient does not need to go under the knife. There are patients who can be managed conservatively, medically, because once you operate on a patient, you own him and he owns you for the rest of your life. So some surgical pearls which I advise to carry them. Surgery fortunately has got very less variation. Standardization of steps must be done. Set a goal for every case and don't stop recording your cases. Be a self-critic and try to improve with every surgery. There's something known as surgical maturity which most of the fellows, they might lack. So be calm, be respectful to the staff. Some of the staff members might have been working there for years and you can learn a lot from them. A surgeon with a huge ego and temperament can lead to disastrous outcomes in the OT. So be calm. Then one of the key things what we always teach is that it's the patient first and the surgeon second, not the other way around. Always remember that. Be clear and crisp in communication with your patient. And according to this, something known as the iceberg phenomena. So if your patient is dissatisfied, so 25 patients, if they are dissatisfied, only one will litigate. And we concentrate only on that one. The other 24 will simply walk away from you. They will further tell a 10 each patients, and each of those will tell a further 5 patients. So it's very important to address the grievances of your patients. Another important aspect is patient-centric approach. So we might go and work in a community which might be different from ours. So learn the culture of the community, how patients like to communicate. Don't take a decision for the patient, take a decision with the patient. Because if you take a decision for the patient, if something goes wrong, he's going to blame you. The another key aspect is the safety and quality. You must, since eye is an organ which is in pairs, the correct site, correct procedure, and correct patient surgery is very important. Always keep some indicators like the outcomes, visual outcomes, astigmatism, otitis infection rates, because the simple rule is if you can't measure it, you cannot improve it. Then another thing is a good doctor is the one who does everything right each time and every time. So be honest with your patient. Do not misrepresent your services. Your documentation should be complete. Do not alter your documentation. And most important is do not speak bad about your colleague because you might be on the other side at some point of time. Then another important aspect is documentation. So one of my friends sent me this. So he says that you must document and communicate the documentation, document the communication, and then preserve the communication as well. This is very important. It should be a legible documentation. You must remember that there are 7 C's of documentation. That is clear, comprehensible, concise, confidential, correct, and in the client's language. Another important aspect is the medico-legal aspects, and doctors, they generally have very poor knowledge regarding that. So first thing I tell them is to get an indemnity insurance once they go out. Also important is to know the statutory and legal requirements in your area about what are the requirements of safe patient care. And most important is to have a cluster outbreak policy, because this is a time, although it's rare, but when one does have it, you are in trouble. So you should know whom to contact in times of cluster outbreaks. Then don't stop where you are. Always keep on upgrading your skills. Enroll for new courses. Share your experiences in conferences. Enroll for CMEs. You must learn and unlearn continuously. You must unlearn the wrong things which you have learned and learn the new things. Then accept new challenges. Go on to the more difficult cases when you have done the simpler cases. Embrace new technology. Go on to multifocal and toric IOLs. And if possible, also take up new equipments if it's possible. Then a good doctor also knows when to stop. So I always tell my fellows, don't shy away from taking help. Talk to your mentors. If you are going to do a new case, ask one of your colleagues to be around, and don't go outside your surgical domain. So non-clinical skills are also very important. Some of them might go into a practice. So building a practice, there is a 6-point strategy. Do a SWOT analysis, and your goal should be SMART. That is specific, measurable, achievable, realistic, and tangible. And if you are shifting practice, keep an eye on your present pool of patients. And website presence is a must. Don't be a set and forget model. Keep on upgrading your website. Keep on putting the new doctors or the new services you have. Again, financial sustainability is very important. Consider from where you are going to take the loans. A balance between an income and expenses is very important. Initially, you might buy refurbished equipment, but it should be of good quality, and then slowly when your practice picks up, move on to a good quality equipment or new equipment. Also, insurance empanelment is one advice which I give to them, because it's a way of getting more income. Then another mistake when people make is when they start a practice is to hire untrained staff. Well, we don't realize that it's going to compromise the safety and quality of patient care, one, and secondly, you are going to need to train that staff. So always hire trained staff so that they can train further people, and keep an eye on your retention of the staff. Keep looking into the social financial security of your staff. Then one more aspect is operational sustainability. Initially, if you start a practice, you might have issues with patient volumes. So a lot of the younger fellows, they might want to do a lot of community work. So you must have a segmented pricing system, just like we have in our institute, if possible, from subsidized to the higher packages, because you need to take care of the patients whom you are going to operate free. So it's just like Indian Railways, where you have something for everyone. Finally, communication with the colleagues is very important. You must know that what are going to be your referral models. If somebody is giving you a referral, you must talk back to him on the phone, what is the outcome of the patient. If somebody has sent you a referral, inform him about the outcomes. Become a member of the local body. Attend local CMEs. It is very important. So to sum up, to make a good clinician, it takes a lot of wisdom, level-headedness. Also, it takes a lot of hard work, and above all, a little bit of fearlessness. So one great surgeon says that if somebody asks you to name 3 good surgeons, you must think before you can name the other 2. So such should be the level of self-assurance which you must have. So mentoring itself can be very satisfied, and when you get such compliments or such testimonials from your mentees, it is really satisfying. Thank you so much for your patient hearing.
Beautiful. Lovely talk.
Thank you, Dr. Ashish. Comments from the experts?
I just have, even it applies to the previous talk also. One specific problem that we are facing as an institution for fellowship training is, now whatever is the lacuna that they have in their post-graduation, so they apply for a fellowship to make it up. So it's like an IUG child which is trying to catch up later after birth, something like that. So, so what happens is the level at which they join the fellowship is much lower. So we actually expend our entire time of fellowship training trying to teach what they should have been learning in their post-graduation, including surgical training. So that makes the whole game more complicated now, and that has been the problem. And it's been very difficult because normally what happens in a fellowship training interview, like somebody who has done 3 cataracts or tried 3 cataracts rather, another who has done 100 cataracts, the person who has done 100 cataracts will be given probably a upper this one leverage and will be taken as a fellow. So there is nothing like a right to education thing in fellowship. I think something has to be done because there's been a growing problem. We had a person who came for a fellowship. Dr. Meenakshi will be surprised. She had never seen, she hadn't had binocular vision her entire PG. She always saw double when operating, and she had done her PG operating a single digit number. And she said, I've never seen with my both eyes. I've always operated one eye. So that means that kind of things also happen. So that has been the situation, and things are really in dire state.
Do you find the DNB students better than the MS?
I think let us not start.
Let
us not start a controversy, but
we can discuss. We can discuss.
I think it's it's about the institution. There are certain DNB institutions where the training is not so appropriate. There are certain, MS where there's a humongous amount of work. So it's basically the institution that matters. It's not about the DNB or MS. It's about the number of patients that are available for surgical training and the amount of facility that the institution has. About the number of students that train.
KP, the reason I asked the question was MS is mainly in the private medical colleges, whereas DNB is all in the private eye hospitals, which are more technologically driven, better than the private medical colleges. So generally, I'm talking.
Maybe there is probably an element of advantage because most of the DNB institutions are exclusive eye hospitals where there is a lot of focus on getting the upgrading of their equipments and things like that. And medical colleges, the ophthalmology department is not always taken care. They're always there's a low priority area in a medical college. Yeah. So obviously, in a group of different specialities, ophthalmology will probably take a back seat. So that could be the only disadvantage. Otherwise, it all depends on the institution, the type of mentors they have.
No, I would like to add something else. Now, DNBs are in private, but most of the private hospitals, they are, especially for DNB, they are cataract focused. So, for a DNB guy, per person, postgraduate, to be completely or holistically ophthalmologist, this DNB training sometimes comes in the way because he becomes an excellent cataract surgeon, but most of his other things kind of go by the wayside.
I'm not talking about that. I'm talking about this basic surgical skills when they come to you. That's what.
But again, that will be limited to cataract. What he's saying is.
Yeah.
Having the college, you have access to.
Medical college always makes a huge difference. You also have non-ophthalmic patients.
Theoretically, they are very strong.
Yes.
The MS guys are very strong at theory. Sushmita, you want to say something?
Yeah, I think it all boils down to we need to really think about standardizing our MS program or whatever program. The reason why the MS program in India is where it is, and why do people insist upon an FRCS for a Middle East job or an American board specialist is because of standardization. Because if I see an FRCS or FRC Opht, I know that there is a basic level of ophthalmology competence that he has achieved. That's the only way he could have passed that exit exam. But that's not true for MS ophthalmology, and we need to, as teachers, do something about that. Why is it that it is taken that we are bad if a student fails? I have never heard a student say that the Royal College is bad because I couldn't clear the exam. How does a medical college become bad if a student fails? I don't understand that. You are not up to the mark, and why should it be another point? Maybe I don't know how we can do about it, but is our sticking to a time schedule. When you are ready with a minimum 7-year training, when you are ready, you go and take your FRCS exam. Nobody tells you to take your FRCS exam on this day exactly 7 years from the time you joined. No, you require a minimum 5 years for an American board specialty, minimum 7 years for FRCS. It could be 8 years later, it could be 9 years. I've just had a baby. I can't take my exam now. You pay your fees and take the exam, but it's depending on competency. If you are paying to take your exam, it is up to you to come up to our mark. And our MS and DNB both are very, very institution dependent. Therefore, when we select, for us, we select senior residents, not PGs. If it's from Institute A, bare minimum kar liya hoga. If it's in Institute B, baap re, pooch lo yaar, pata nahi kya kiya hoga. So that's the problem, I think. That's my take on our education right now.
And today it's complicated by the COVID batches.
Absolutely.
Unfortunately.
A huge problem.
Unfortunately.
Huge problem, yes.
Thank you so much for that discussion. We'll move on to the next speaker, Dr. P. Selvam, who will be speaking on enhancing surgical prowess through camp activities, the schedule and the need.
Good afternoon. Thanks, AIOC, for the invitation. What you measure is what you get. So this is what I measure my surgical training program. At the end of the course, the candidate should do independently. But at what cost? There should not be any compromise on patient safety and quality. Just because they are operating on a camp patient or a charity route, we cannot take it for granted. With this in mind, I set a SMART goal. Specific, measurable, attainable, realistic, and time bound. So how to proceed? So how to run a SMART program? This is our program, usually for 15 days, 10 operating days, Monday, Tuesday, Thursday, Friday. It's a standardized teaching and only basic technique, 4 quarter, period. The whole purpose of this 10-day program for them is they should understand the concept. And the attention is given to the motor skill, hand-leg coordination. And this 4-quadrant technique really helps us. And it is not from start to finish. We start non-linear. We usually start with the phaco part. We do the section, we do the rexis, hydrodissection, initial trenching, and we ask them to do. So first is understanding, coordination, the microscope, like what you said, how they view it. All these things are corrected, and this 4-quadrant technique gives us the time, and we can always intervene. And basic thing in 15 days, we don't know their background, they should develop the sensitivity to the ocular tissue. That many of them, they do rough handling. And the program is concentrating mainly on how to avoid complications. There are more don'ts rather than do's. So finally, at the end of this 15 days, they develop that inner confidence that they can do this surgery or they cannot. So based on that, they can extend it or they can proceed it. We are not making them expert, but we are making them aware. This is what the surgery is all about. So method. So in 4-quadrant, this is what we do. Ask them correct way of holding and make them realize it is not the hand that is doing surgery, it is the leg that is doing surgery. How much pressure that you should do, how much power should be there. And in this, we teach them the coordination of left hand movement, how to place this left hand and how to do it. The position is very important. Next is climax. Make them experience phaco or whatever it is. So how do it? This is the most part, everybody is worried and a lot of intervention happening. So we make them do it, slow down and make them do that handling. Keep it straight, horizontal. Let the tip or the nucleus piece come to you. So this teaching comes, they understand this is what is happening. Typically make them slow down so that they can really feel this is what phaco is all about. So in that way they are able to understand it better. Complication, any training program. We cannot shy away from complication and we have to measure it. In our case it is 5 to 7%, but we have a management protocol. Complication cannot be avoided, but if the complication happen, and remember in a camp surgery it's a high volume, it's an assembly line production and one person stops and the whole system goes out. So what we learned is if there is a PC rent, stop then and there, come out. There is no point injecting viscoelastic, calling the senior. If it is fair, and the sisters are trained in that. So once that happens, we do it later. On a Saturday, the tinkering work starts. We evaluate the patient, we see that he is quiet, Then we do the secondary IOL. So in that way, they understand how the complications are not on the table that really disturb the whole process. And we also have mapped out where the complications happen. So that way, usually in SICS, cortical aspiration is a major point. In phaco, the same thing. And the last piece. These are the areas where we give more attention and people really. And in spite of all these things, we cannot be present. We should have a communication or information coming to the theater. Everything is going well. Because we see people from different backgrounds and they have different ambition or innovative style, but it should be approachable to the or standardized. So what are the requirements in running a program like that? We should have a proper infrastructure. And there should be a constant stream of patient availability. And there should be a trained trainer, and there should be enough time for the fellow to understand the surgery. And ultimately, they should have a passion. You should really be willing to teach. It's a back-breaking job. So it's not that easy that you have a constant stream of, you have high volume camp patient, you can run the program. Unless we are really interested in teaching, this program cannot be successful. So the ecosystem, trainer, trainee, and the patient, you should not forget. So what are the qualities of a trainer? Experience, confident, alert, analytical, courage, compassion, more than the listening part. We should understand the background of the trainee and what he wants and how we can incorporate. We should be really compassionate about them because he has come to learn all the way from far off place, spending his time, spending his money, and he has come us to learn, and we should have the responsibility of teaching. This basic thing should be necessary in a trainer. And the trainee, he should be humble, responsible, patient, well-read, practice, well said. But how do we incorporate a person from a different background? It is the culture of the organization. If you really see, like what Dr. said about professionalism, if you really care about the patient and all your whole system is geared towards that, then the person understands this is a serious business. We are not just because he has paid some money, he cannot take things for granted. So that has to be insisted. And the patient concern. Yes, the patient wants, and we also want safety and good outcome. One more thing is the table time. Patient always look at the quality, the amount of time that he spends on the table. So we have to be really careful. And for a trainee, it takes a longer time. Understood. So what we have learned over a period is how to reduce the table time. So my height and my trainee height are different. So we have two different stools of different height. The table, microscope height are standardized. So what we do is we have one person shifting because it is very difficult to control the surgery through the monitor. So we have to look through the microscope. The side microscope are not very comfortable. So we do that. And only few steps a day. 30 cases assured, 4 days surgery. So you are assured one step you finish, you move to the next step. So day 1, we know what we are going to teach. Day 5, we know what we are going to do. So at the end of day 9 or 10, he should be in a position to fully do the surgery. This is how. And no discussion during surgery. It's always afterwards. So you reduce the time. And only instructions, especially monosyllables. Do, stop, come out, enough, give more power. So order. It is only what I say. On the table, in that level, it is me who is dictating, you do it. Don't stop arguing. Only selection. Last month he has finished DNB. A lot of recommendation, take me for surgery. No. Minimum 3 years. They should go back and also see where they are coming from, where they are going to go back. If they are going to go back and do surgery only, we take up. Because my time is also precious, my patient's vision is also precious. And they should be in a position to understand the pain of the patient. This is very important. So challenges, complications, managing those complications, a lot of cost involved in setting up a program, and the case availability, or a medico-legal aspect, and finally the reputation of the institution. These are all very important. Rewards. That is self-improvement. The more you teach, the better you become. And the institution is built on that reputation. And there is a recognition. Finally, above all, it's a satisfaction. So this is what we get. finally, what gives me more pleasure is a satisfied patient. Thank you.
Thank you so much, sir, for that presentation. I had a question for a lot of studies that we do, presentations in the journals. We have a medical review committee, so on and so forth, ethics committee. When the patient is getting operated in your institution, do you take a consent from the patient that the student will be operating on your patient and we will be actually teaching him during the surgery?
No, sir.
Is that, what is the views of the house of whether that is legal or illegal or it's okay?
We don't do that also.
No, I don't think that is the issue.
When we have, that is an issue. When
no,
you
no.
are doing
It's
so
not-
much,
it's not
ethics
like-
committee is there for an article. When you are operating on a human being, we don't tell that somebody is going to learn on you.
Good question. Yeah.
No, but see, basically in Indian setup, it's an assumed consent. It's a presumed consent, whatever. So it's here probably the people who have done the post graduation are getting trained. They are equipped with the thing.
Sir,
to
my
practice.
question is whether the patient knows or
where
not.
is the learning?
The
Even I
patient
am a
has given
learner.
a consent.
Even I am a learner today. Even today also I am a learning cataract surgery. So there's nothing like a learner and somebody who has learnt. So
But the patient has come to Joshi Eye Hospital thinking that all are learned here.
No. The point is learning never stops in that case. Here there's a postgraduate who has already finished postgraduate and come for a further training. He is legally having an MS degree or DNB degree.
Sir, consent from the patient. That is the question.
No, I don't think.
Do you
consent is
tell the
taken
patient
anywhere.
that the person who is going to operate on you is
nobody
going
will
to
get
learn?
operated.
Nobody tells.
Nobody will
Is
get
that
operated.
legal or illegal?
No, we are not sure whether it's illegal. Nobody knows the question, answer for that.
No, more than legality, whether it's
Trainer
ethical.
and the trainer.
Why
both.
ethical? I can rephrase my question. Whether it's ethical or not ethical.
No.
Yeah, so-
Legally, from legal aspect, absolutely a person who's postgraduate, doesn't matter, he can be 50 years of experience or 30 years experience. He can be very bad in surgery. There are so many surgeons who have learned, finished PG.
But
and
he can
done.
operate.
But he can legally,
legally he can operate.
As a patient, was I to be informed or not that he
As
has
of
done
now, there
only
is no
one
legal-
cataract surgery
yeah.
and is next he is going to operate on my eye?
As of now, legally, there is no that it has to be compulsory told to the patient that you are being learnt on your eye. There is not that, definitely.
We have so
legally.
many policies to write an article in the Indian Journal of Ophthalmology.
Right,
So
sir.
many ethics committee, this committee, that committee. But for surgery, we don't take the consent of the
No,
patient.
but what he's saying is they have the surgeon's name written and the other surgeons who is assisting his
Both
name
the
is written.
surgeons.
Both the
The
surgeon name
training
is
and
what-
the
so
training
that
is
is, I think,
recorded.
more
But
than
the
sufficient.
assistant is actually the operating
Satyajit,
surgeon.
What we do is we ask the trainees to talk to the patient before the surgery. All the patients
And
are
tell him that I'm going to operate and I don't have experience.
Tell the name of to the, but not the experience and all that. But tell the patient that he's going to operate on it. So such and such a person is going to operate with the name. So to the patient, we tell them.
I think that this is a bit difficult question to answer, definitely a tricky situation. But I think legally you are right. If someone has an MS or MD degree, he can do that. But the question is, before you have achieved the MS or MS degree, you need to train them at that point of time also. And then legally you are not covered. So I think...
Legally it's not a problem, sir. You're not asking an optometrist or a technician to operate.
No,
you are asking only a
You have not
postgraduate.
taken the consent of the patient.
No.
Yes.
The consent of the patient, that's what. The oral consent is given. Not the
No,
written
consent of
That
the
a second
patient.
year postgraduate will be
the-
operating on
the
you.
The trainee in our setup, I'm sure Paneer is also doing that. See, please, for the information of everybody, Paneer Selvam has got one of the most popular phaco training programs in the entire country.
This question is not only for him.
No,
it's
no,
for
I'm just telling you.
everybody.
I'm telling you,
even
I
abroad-
ask all the trainees to talk to the patients, mention the name of the doctor to the patient. And suddenly I'll go and random check. I'll ask the patient who's going to operate on you. If the patient does not say the name of the doctor, I will not give the surgery to the patient, to the doctor.
I think
basically-
Dr. Sushmita was saying, like Royal College will have to have a what do you call that?
So actually, even abroad,
In
sir,
place.
what they say is there is a primary doctor, then there are assistants. So assistants come under trainees. Eventually, they are the ones who are learning from the primary doctor or helping the primary doctor to complete the case. So even in abroad also, if they are being trained or the student, the doctor doesn't go to the patient saying that your eye is going to be the source of my learning, I'm going to do it, and then they start. Absolutely not.
Is that ethical?
But
I think there also
definitely, sir.
Doesn't the patient have the right to know?
No, there is also a,
Yes, ma'am.
there's also a, separation between the, private run hospitals and the public run hospitals in abroad. Because if you're going to a public hospital and the consultant who sees you, he is understood that he has trainees with him. But in a private, you are going to a specific doctor and you want to be operated by him. So I think that issue was.
And what
I
about
don't know
the
how
foreign
you
trainees?
deal with that. Yeah.
Correct.
Yeah,
We
so
get the
I-
permission from the medical council.
Yeah.
And properly. And we take them any
Medical
medical
council,
legal problem, it is the trainer who is responsible.
Yes.
And we
It's
give an
written there,
undertaking to
yes.
that. So it is a proper rule.
I did fellowship in the University of Iowa, and we did hands-on training. So a patient would off and on ask Dr. Scott, my mentor, will you be doing the surgery? He would always say, I and my team.
Yeah.
Okay, because that is the truth. If the patient, you cannot tell every patient my training is going to be doing. It is implied when you come to a teaching hospital that the trainee will participate in the surgery. We don't know what percentage, but they will participate. Never in private practice, when you're in private practice, you never usually no trainees in private practice, I'm talking of the US, it's always in university hospitals. So the answer is, it is implied, one. Number two, they always would say it's my team. So, which includes the training.
So
And many a time the patient himself will know, are you teaching on my eye? So that is why we always take it care that less discussion, monosyllables, just instruction, all these things are done just to, otherwise he will lose confidence. And the table time is very important only because, not that we are hiding something, but the patient's confidence should not be lost. This is the only reason.
Virender, sir?
And anything is responsibility of the institution.
Yeah, actually, that is very correct, because when I was in Moorfields, I asked them the first day that why do you operate all patients under GA? They said because it's a training hospital. That is the reason we operate under GA. All patients, everything, even a Calazian is done under GA.
Caladian under GA?
Yes.
No, just the patient should not know and should not do content. But my question from you is that what about PGs? This is not about
वो हम सब समझ गए. What is being done is correct. तो नहीं होगा तो teaching कैसे होगा? वो तो हम समझ गए. But is it ethical that the patient does not know that my eye is being operated by a trainee? That is my question. The system is correct. उसमें कोई दिक्कत नहीं है.
I think ideally they should know it. I mean, they have
Yes,
they have the right to know it. So ideally they should know it. But how you put it, that's the question.
somebody doing MS only, when the consent should be the same.
Thank you, sir. We'll go on to the next topic.
Rajesh will go for next.
हैं? कहाँ है राजेश?
Yeah,
Paneer.
I think Dr. Rajesh has to go in other sessions, so
हाँ बोलो
he'll be-
topic.
yeah. He'll be speaking on enhancing skill sets in publications. Dr. Rajesh.
Thank you, Dr. Harshul, and thank you, ARC, for inviting me in this session. After something very interesting which I was actually listening to regarding patient care, and we all are so much, keen and so much engrossed when we do patient care and discuss about it, that a topic regarding enhancing skill sets in publication will be a bit, maybe a breath of fresh air. That's a very nice word, so thanks a lot. So the question is why we should publish, and we have a lot of teachers, a lot of publishers sitting here. So we all know that whatever we do, if we do any study, unless it is published, unless you publish the results, that is not the end of it. I mean, you are not considered to have completed the study, and that's why we should publish it. The question is that why is it really important whether research in residency is important? The question is yes, because it allows the resident to start thinking logically, think about methodology, think about something new. He can become a better doctor if he applies logic based on certain methodologies, based on research ideas, based on many other things. And idea and understanding of research technique really helps a resident to become a complete doctor. Now, this was one survey that was done, and they've tried to figure out why residents are not very much into research. And it was found out that lack of time was cited as the most common reason, and they felt that most of the times they are consumed in the clinical work, and that is why they are not able to do research work. So, how to get residents into research? We will have to make a curriculum, and we have to, give some incentive for research, because, like, say, for example, somebody who is doing a post-graduation and now appearing for a senior residency exam or a registrarship or any other, there should be something, they should be given points for, having research articles, and that is an incentive for research. And further, they should be allowed by their mentors to go and present in various conferences, and that is how they will get more encouragement, and that will help them to go into research. And telling a resident to go into research sometimes, makes him feel a bit, terrible, that, how can I do a research? So you have to start with a very broad beginning. Ask the resident to, regarding any patient, if he can search, he can do literature search regarding what exactly is the treatment modality, what is missing in it, how we can improve upon it, and that is how you can, get a research question on a particular condition, a particular patient, and you will inculcate that habit into the resident. So, most important thing is that the research that is being done by the resident has to be published, and that skill, that basic understanding of how one should write a manuscript, that should also be explained to the resident. So it is, as we all know, the format is IMRAD, that is Introduction, Method, Results, and Discussion. And these are the components like title, authors, abstract, keywords, introduction, method, result, discussion, acknowledgement, reference, appendices. And before starting writing an article, one should always check the author guidelines of a particular journal and then decide about the article. The title is actually the main board. See, if you write something on the main front board and that is attractive, that will attract readers towards your article. So that is the advertisement for the article. So that's very important. One should be very careful. One should try to be concise, try to figure out what can be the keywords related to the manuscript, and then think of a title which should be of less than 12 words and less than 100 characters. And it should not have abbreviations or proprietary names or jargons or anything that you just think casually. And after writing the title, you have to decide about the authorship. And a lot of issues come as far as authorship is concerned. This happens in many institutions as well. So who all should be authors? Author should be the one who should actually contribute to the research. And if a student is doing a thesis, then ideally the first name should be of the student, and then of course the guide, the co-guides, etc. And the technicians who have been helping, they can be kept in acknowledgement. As far as the abstract is concerned, it gives you the brief summary about what exactly has been done in the study, and that can be depending upon what manuscript you are writing, whether it's a technique or it's a full article. It depends on the number of words will vary from 150 to 250 words, and it should best be written after you have written the article completely, so that you can write a very good abstract after writing the article completely. And of course, it should not have references. It should be written in past tense. It refers to the work done, and there should be limited figures into it, not the whole of results, etc. So you have to follow a certain format. When you are writing the manuscript, you write the introduction. So the first thing is that what problem you are investigating, what are the background that are, background information that is present in literature, and how different is your study that you write in the last sentence, that in this particular study we are going to do this. So, and of course, the reasons for conducting the research, obviously, that is the research question. And introduction should not be very long. It should not be too short as well. It should briefly describe the experiment or hypothesis that you are planning for. And you use the present tense when referring to the work that has already been published, and you use past tense when you are referring to your own study. And use the active voice. When I was writing articles, I mean, still I'm writing. So what happens that sometimes I have also got this kind of a reviewer comment that in this part it should be written in active rather than passive. So that is something which we all learn by doing more. So use the active voice as much as possible, and cite peer-reviewed scientific literature. As far as materials and methods is concerned, we should be writing in complete details in such a manner that somebody who is reading your article, he can replicate that, he can do that research in his own center. So he can replicate your research. That is how it should be written. And it should include everything, including patients, including the instruments, including the details of all the technique and inclusion and exclusion criteria, etc. And it should also deal with whatever, whether it's a human subject, it's an experimental study, or whatever it is. Now, as far as result is concerned, it is the core or heart of the paper, and it should give all the details of what all has been found out. Primarily, what was the aim for the study, so all those results should be written. And then secondarily, what more things were noted, all those things have to be written, and it should be written very clearly, and no inference on the result should be written in the results. It should be absolute data that what all these things were noted in the results. And if there is too much of data related to one particular thing, you can make it a table. Or if there's a trend, like there's an increase or decrease, that can be best depicted by a figure. So that is something that we have to take care. And as I said, the material related to table should not be duplicated in the results section. It should be separate. And of course, figures also should not be duplicated in the results. As far as discussion is concerned, that is the most important thing, the most difficult thing, because you have to understand what exactly has been done, what is your the results, what are the results of your study, and then you have to compare with the existing literature, and then write about how this article is going to add information to the existing literature. So you have to write what all is known and what is being added by this manuscript. So it's classified based on, first paragraph you write major findings, then middle paragraph you based on major results, etc. And the last paragraph you write about, what you finally infer and what is your conclusion. And the most important thing is that the conclusion should not extrapolate certain things which are slightly away from the exact result. Sometimes we have a tendency to infer something more than what exactly is the result. So the conclusion should be based on exactly what findings, what data you got in the study. And as I said, acknowledgements can be mentioned, and the technical staffs, etc., they all can be included in the acknowledgement section. And the reference can be written based on the author guidelines of the journal. It can be Vancouver style or Harvard style, alphabet number system, citation order system, everything. One of the most important thing is that there is no place for gut feeling in the article, in a manuscript. And quotes, etc., should be avoided. So these things should be avoided. It should always be based on what exactly is the data. So thank you very much for your patient listening, and I would really love to have some points from so many learned members sitting here.
Thank you so much, Dr. Rajesh, for that wonderful talk. So my question is, first, which journal do you choose to publish in first? You prefer IGO or?
Actually,
see, we are always now stressing that we should first send publication for IGO. So
ideally speaking, if I have presented a paper in AIOS, the first right of refusal is of IGO. If I have presented a paper in American Academy, the first right of refusal is ophthalmology, or maybe you can send to JCRS, etc. So that is how I divide. If I have presented a paper in American Academy, then obviously the first right of refusal is of the journal that is linked to that. So I will send the manuscript to ophthalmology or to say JCRS, etc. But if I have presented something in AIOS, a paper in AIOS, then obviously I will send it to IGO.
What's the opinion of the expert panel?
I think some journals have that binding that if you're presenting in American Academy, you have to.
You have to do it.
You have to do it to the American,
No, if you're not presented, you're just
ophthalmology
writing
first.
a fresh manuscript.
Presented, presented.
What
Yeah,
is your
you have
thought
to.
process like?
But I think apart from that, most people go by the impact factor, the circulation of the journal, where is there more visibility of your work. So I think that probably remains the number one criteria. I would say, if you think your work is worthwhile publishing somewhere, I think you will always try to publish in a journal which has a high impact factor and more circulation.
No,
Because
is
that
there a
gives you
thought
more
process that
visibility.
if you publish in JCRS, that will have more impact than IGO? Is that thought process is still there?
I think so, because
so. It is
definitely,
there.
yes.
I mean, we have to accept the fact that it is there.
The bigger impact factor is definitely better with the JCRS. Very good
I think
presentation, Rajesh.
for a private practitioner, it's a real big task to publish. So, what tips you'd like to give? Because in institute, it's fine because of course, you have to publish also because of the certain regulations and all those things. But private practitioner, I think hardly they publish in their entire career.
I think for private practitioners, I would say the first and foremost thing is that everybody gets interesting cases, and case reports. Anyone can publish, so that is something which you can definitely publish. The second thing is that 2-3 hospitals can join hands and then can pool up data and then can go ahead and publish it with names of all the 2-3 hospital doctors. So that can be done. One challenge is to have an ethics committee because ethics approval is again an issue. So that is something which has to be worked on. And that is something which actually today also we were discussing even in our meeting in ARC that we will try to figure out from AIOS that if we can have a society ethics committee, and if that can help members and how that can help, we will have to work on it, because there is a definite perimeter within which if you have an ethics committee within 100 kilometers or something, then you can still apply in that ethics committee. So there are certain limitations for people who are in the periphery. As far as a single case report or a retrospective finding, observational case report is concerned, anybody and everybody can publish.
No, there are independent ethics committees even in India now. Some are by the ICMR, some are by the DCGI. There are certain institutes or universities which offer their ethics committee for a certain radius of perimeter. So that shouldn't be the deterrent. But my take would be, don't publish for the sake of publishing. Say something, if you really want to say something, that's when, and that's where your heart would be. When you want to give a message. I can give an example of congenital primary aphakia, which I didn't know until Dr. Murli published. And what he wanted to teach was that if you get into an eye with CPA, it'll go into phthisis. So it was a negative. He didn't want to say that I'm so great that I can do CPA. He published 9 cases, 9 out of 9 went into phthisis, but he published it to tell the world, don't do it. So when you have a message, that's what's important.
Absolutely.
Very nice.
It's all about, for a private practitioner, that they don't document at that time. If somebody has 100 OPD and a very interesting case comes, he won't document it. Probably there are a lot of very good talent in the, they can come out. Only thing is that at that time, they should actually kind of completely document it and try to follow it up so that they have some data for later to work on. So in an institution, that is the advantage. There are somebody else down the grade, down the hierarchy to do that.
So it's not that difficult. I would say on the same note as Dr. Shushmita said, that if you want to immortalize your work, You need to actually publish it. And that is the feeling that you should have, not that I want to publish it because I want my name in the journal. That's number one. And number two is that it's not that difficult, because we've had an ethics committee for last almost, 15 years, and we've renewed it thrice already. We didn't have any problems in renewing, and you do have people who help you out with the paperwork.
True.
You don't have to do all the paperwork. There are agencies who help you out with the paperwork, and you can do it. And what you said rightly is that within 50 kilometers, you can actually use the same ethics committee. So we do get requests from hospitals nearby who say they'll use
50 kilometer radius actually.
Yes, yes.
Yeah.
50
But
kilometer
100
radius,
yeah.
We do get requests, and we do, of course, help them out if the paper is worth publishing, but we do have our constraints as well. We look at the paper and then we take a call on that, basically.
True.
I think the IGO case reports are very good.
Yeah.
I think it's a very good platform for all the private practitioners.
Yeah.
The IGO case reports, what Santosh is doing is really fantastic.
Yeah.
Very easy also to do
Yeah.
it.
Thank you very much, Dr.
Thank you.
Rajesh.
I invite Dr. Shrisha Sendil, consultant LVP Hyderabad, to give a talk on glaucoma surgical training schedule and further.
Thank you and good afternoon. Do we still have time?
Yes,
Or
why not?
Do we hand over to the next session? No.
We have another 15 minutes to go.
15 minutes to go.
2:15, no?
All right. 10 minutes. Fine.
We have Tamil Rishis talk after that.
So as the presentation is coming up, wonderful sessions and a lot to learn. So I would like to start by how do we choose a fellow? I think a lot of discussion was going on about, where do they come from and how was the training and how has the COVID impacted the training and things like that. In fact, one of the most disturbing days for me is the day I do the fellowship interviews. You know that these kids are extremely talented. If somebody has to be a doctor, imagine the amount of effort somebody has to put in from the time they start their schooling to get into a medical college, to get into a post-graduation, and after that to come into a fellowship program. So they have spent, or rather in the brackets you would say wasted, a lot of time, sometimes in the premier institutes, they're okay, but let's say a little bit less than that, absolutely wasted their 3 years of time, and then now you want to come back and do a 3-year fellowship and maybe do some more. So learning from where you ended is different than learning from the scratch. To unlearn a certain things is very, very difficult. So in fact, I go back home and then, if my husband asks me how was the interview, so I would say kids were fantastic, but it was disastrous that either they did not utilize the facility that they had, or they were in a place where they just did not have a facility. Although we say, YouTubes are there and there are several things to teach them, but we need to understand you need to have a mentor who will either inspire you or handhold you and take you through, which is very, very important. And I think from having no fellowship programs in our country to having several programs today, and some of them that run so well, I think we have come a long way. But we do have a lot of responsibility, and I think we can definitely, together as a group, help to improve the fellowship program. So this is a question that is normally asked. In fact, I have a few people who come and joke, glaucoma is all about reducing the intraocular pressure. Do you really need a fellowship for that? It is actually not wrong. And when they get into the fellowship, in fact, there are some fellows who come to us who say that, let me be truthful, I actually don't want to do a glaucoma, but because this is a part of the anterior segment, I have wanted to do either cataract, refractive, or cornea. Because I didn't get in there, I'm coming into glaucoma, because glaucoma also gives you cataract surgeries. This is what we hear. Some of them are very blatant and they tell you that this is what it is, because glaucoma anyway you can treat medically, that's not a problem. But once they get into the fellowship, the more you know, more you realize that you don't know a lot. So it is very important to actually put that into perspective. I would look at it this way. Our population is aging, and the need for glaucoma training and fellowship training is very, very important. I would also go one step back and say, we have actually at LV Prasad changed our fellowship training for the past 3 years. Why did we do this? Earlier, it used to be a 2-year fellowship. It used to be 1.5 years, then it became a 2-year fellowship where people are taken into subspecialty. Now the fellowship structure is completely changed. It's a 3-year fellowship program. The first year, irrespective of where they come from, they could be coming from PGI, AIMS, they could be coming from one of the most, the smallest private centers up north or down south. All of them go through the same curriculum. The first year, they rotate through all the specialities, which is a divided curriculum. You have a mentor specialty. That means if somebody is joined into glaucoma fellowship, they are, let's say, I am the mentor. Each fellow is given a mentor when they join. So that mentor is a person who will take you through the entire 3 years, be it your education, be it your training, surgical training, your research, whatever it is, you have a mentor. Apart from that, you also have a faculty guide. The faculty guide is outside of your fellowship. Like the glaucoma fellow will have a mentor who's a cornea person or somebody like that. So why we did this is because they could be a well-trained retina specialist, but they don't know how to detect a glaucomatous disc change. Then it is a disaster. So we decided that everybody goes through that initial 1 year to go through the training of all the specialities, that there is a basic minimum that everybody needs to learn. And the second year, they do their rural posting of 1 year, where they take care of So the retina fellow is also taught cataracts, the plasty fellow is also taught cataracts. So basic training is given to everybody. Yes, one may say that they are eating into somebody else's practice. Nobody eats into anybody's practice. They just become better doctors and better surgeons, right? Everybody, and as far as glaucoma is concerned, they have to learn their gonioscopy, disc evaluation, and medical management. And there are certain diseases that they have to learn, like lens-induced glaucomas and things like that, which is mandatory before, and it is certified before they go to their rural posting of 1 year. 1 year, they are independently there, they're managing. In fact, several people come back, and the third year when they're coming back, in fact, there are people who have changed their fellowship. Meaning somebody wanted to do retina, and now at the end of the second year, they come and tell us, no, I would like to do glaucoma, or I would like to do a different specialty, because I see there is a huge need in the community. Because when they come for the fellowship program, when they actually apply for the interview, they tell multiple things. When you ask them, why do you want to do a fellowship? Either it is too complex, I don't understand this disease, that's why I want to do, or the latest surgery I want to learn, that's why I want to do. But then when they are in reality, when you are there in the periphery, when you are there in the clinics, actually the reality hits you, and what you want to learn, actually you discover when you're going through. So I think this is very, very pertinent and very important, because several of our patients live in the rural communities, and we need to make sure that all the general ophthalmologists are empowered to diagnose diseases like glaucoma and diabetic retinopathy, where you at least can save people from going blind. Cataract is important, very important, but I think these are diseases where we need to definitely empower our people to be trained and to take care of the patients. So in our training program, what we actually help them is, everything is divided into 3 things: patient care, education, and research. When you say patient care, how to deal with the patients and how to take care of them, starting from your clinical training to your surgical training. Education is a very integral part of it, be it journal clubs, be it the case presentations, be it how to start a PowerPoint presentation. Many people won't even know that when they come to you. Starting from the punctuations to the way they deliver their presentation, everything is mentored and handheld. And also the research is the same way. But what is very important, and what we found was very interesting, is you have a junior fellow and you have a senior fellow who is hand-holding. In fact, that person is the mentor, and you have a moderator. The moderator is actually the faculty. So they come to the faculty only if that second level is not taken care of. Majority of the time, they're usually taken care of, and that way actually when they start teaching their junior colleagues, they become much better. So it is a kind of a structured thing which helps them. A curriculum is usually planned, and when a fellow is taken into a fellowship, even before they join this particular, let's say somebody was asking about how often do you update. In fact, we often update it almost on a yearly basis, and that particular curriculum which is there, which means it's a compilation of the reading material, the surgical videos, a lot of things that they need to learn. Even before they join, they actually prepare and come. And in the first 3 months, they have an exam, which actually is to understand how much of this. Several of them have not even opened them and read it, but to understand whether they got into the into the specifics of what they are supposed to be expecting and what they are supposed to be learning in this 3 years. So diagnosis, of course, is an integral part. The first 3 months is given to the diagnosis part, and then the cataract surgical training, and then comes to the glaucoma training. In fact, when we have several of the international fellows who come, we insist that they have to be good cataract surgeons before they get into the glaucoma program, because it becomes extremely difficult. That 1.5 years, you just spend their time teaching them cataracts and their suturing, because in glaucoma surgery, the error margin is very, very minimal. A small error, and of course, you can have, you can even lose the eye. So this is a very interesting article written by Dr. Ramakrishnan on surgical management of glaucoma in India. So we have several of our ophthalmologists, if you see, are located in urban areas, but the need is mostly in the rural area. So people who are general ophthalmologists who are in the little rural areas, I think have to be empowered to be able to do the basic diagnosis and also the surgical part of it. But surgical part becomes extremely difficult because of the problem in glaucoma surgery. Let me just go to that. So there are huge range of surgeries that are there, and there are certain types of surgeries which are done mostly by the cataract surgeons and not by the glaucoma surgeons, and a mixture of both. So when we have to train somebody, we need to understand what is the basic surgery that we need to teach, and also teach them all the things, including the most latest and the advanced ones, because when they go out, I think you have to empower them to be able to choose what is appropriate to the patient and to be able to do everything that you can do in your patients. I don't believe in, if you are a 3-year fellow and you have spent 3 additional years after your 3 years of your MS, that you go back and seek another fellowship to be able to learn something more. Of course, we keep on learning and new things keep coming, but my fellow should be able to do my entire list on the last day that they leave the fellowship and go. That should be my that should be the aim that each of us should train our fellows with, because people should be comfortable and confident when they go out. So I don't want to go into the specifics because I know we are running out of time. So I said, when we choose to do a surgery, especially with regards to glaucoma, several of them are treated medically, but if you choose to do a surgery, it needs to be a precise surgery, because you do want pressure control, and definitely the risk of complications are extremely high. So the margin between somebody doing a surgery well versus a small complication or a problem is very, very minimal, and that small complication or a problem can actually lead to an irreversible loss in vision. So we need to be extremely careful. We need to handhold them and teach them, and if there's any problem, I think we never go away of the side scope. So either you are sitting and training or your senior fellow is sitting and training, and it has to be followed up in the post-operative period. So we need to learn a lot from the cataract surgical training, that you need to have a structured curriculum. Wet lab is extremely important. Unless they do a certain number of cases in the wet lab, they will not translate into the patient number of suturing before they actually come in and start the trabeculectomy. Assisting surgery is very, very important. Stepwise surgical training, surgical recording. In fact, we have a class every month where the fellows actually show their surgeries that they have done, and the faculty is the panel sitting there. They just play it and say, this is what I've done. What do you think is wrong? How should I have done it differently? Or something like this happened, and the outcome that I saw on day 1 post-op was very different. Why do you think it happened? In fact, they are given that privilege to ask that question, and one whole class is dedicated to that, because that is how they learn. And then we tell them, bring in your unedited videos, because that will help you, and that will help us also to understand and help them train as well. I think we need to be open to be able to help them. So this is the program that we have as far as trabeculectomy training is concerned. I'm not going to the details of it. ICO has a very, very nice rubric that they go through. I think this rubric is very important for us. In fact, when I first looked at the cataract training rubric, I was surprised. Starting from how do you introduce yourself to the patient, starting from how do you talk to the patient, pre-operative evaluation, to every single step that you need to do and the instruments that you need to use was fantastic. To me, it was a learning actually. After that, of course, you do have what is available for trabeculectomy as well. And recently, we also published a rubric for AGV implantation. So basically, because you don't have anything, and how do you teach a fellow or train a fellow? So you need to go through every step, and this is something that we follow very rigorously. And the fellow will not touch a complicated case unless they have moved on from here to here. It's not the number, I think it is their skill that is most important, and the complications are obviously have to be taken care of. So ultimately, at the end of their fellowship, what is it that you want them to do? You want them to be a confident and a good ophthalmologist, taking care of the entire spectrum of the conditions that they come across, to be a good glaucoma specialist, and more importantly, to be somebody who can come back and teach or train people, whether it is in their private practice or whether they, they are in an institutional practice. They should be able to help to impart knowledge to the next generation as well. And an independent clinic and surgery towards the end of their fellowship is extremely important. When I ask my fellows, what is it that helped you the most? When they are finishing, they tell you that the independent clinic that I did, 20 patients I saw the entire day. I was just, it was very difficult for me, but they learned the maximum during that time because they take independent decisions. Of course, you have a parallel clinic running. They can always come back and ask you. So we need to make them more confident and, of course, with least number of errors and problems to the patients. That's it I have. Thank you.
Thank you, ma'am, for the excellent talk. Any questions? Should I go with my presentation, sir? Or? I'll make it very short. Can you open it? Good afternoon all. I'll be talking on maintaining a logbook. Logbook are introduced in clinical education to enhance and monitor students' learning. But clinical experience shows they're not always optimally employed. In the next few minutes, I'll be trying to share my experience on implementing the logbook. Why do we need it? The quality of any clinical training depends upon multiple factors, the important one being the number of patients and also the educational expertise of the trainer. No two trainers are exactly the same. So to ensure consistent quality and standards in the learner's experience at multiple levels of training, logbooks are employed. What are they? They are nothing but a set of learning objectives for the specified educational time period. So the learner will be already aware of it and know what to do. So this keeps them better engaged in the learning process and it improves the structure of the training. It's not moving. Okay. This is the page what we had in the existing logbook where they enter the pre-op details, the operative notes, and also note the complication and the post-op visual acuity. This looks overall good, but the downside of this is repetitive writing of the same operative notes again and again unless there is any intra-op deviation. This makes it very boring and less engaging, and until and unless it is monitored and mentored, they're not going to fill it in first. And again, though the details of complications and visual acuity are entered, it does not provide any opportunity for data analysis. And the important thing is, by looking at this, I'm not able to assess the performance of the trainee. So I designed and implemented a structured logbook to aid learning and training adapted to the student's need. When I designed, I kept it certain points in my mind that it should be very simple and handy, the contents to the point, and presented in a clear structure, exactly defining the learning objectives. It also should allow for easy data entry and analysis. In short, it should be both a comprehensiveness and simplicity should be there. Always make the content of the logbook should be constructively aligned with the curriculum. That means the learning objective of the curriculum and the learning outcomes of the logbook should always correspond. Our cataract surgery learning curriculum starts at the 4 month of the for SICS once the trainee picks up the comprehensive ocular examination skills. In the final year, they learn to perform phacoemulsification. So the contents of the logbook were listed such that it mirrors the activities, whatever they do in the wet lab and inside the theater. At the beginning, any trainee is introduced on the benefits of using a logbook so that it keeps them engaged. They are asked to submit them weekly to get a better feedback. So it gives both of us a quite overview of the requirements of the training and idea of the learning process. They also attend a series of lectures and write modules from basic anatomy to the complex IOL per calculation. This will be covered in a month and their attendance is documented. They also spend a considerable amount of time in wet lab, 2 to 4 hours, where they practice to use the operating microscope, develop the hand-eye coordination, and practice suturing skills, sclerocorneal tunnel construction, and rhexis. And for phacoemulsification, they perform nucleotomy technique in the wax eye or the frozen nucleus obtained from SICS. All this curriculum is documented and always supervised by a senior surgeon. So this is perceived as a trigger for learning. And this training is not a fixed session. Even after entering the OR, if they learn to enhance or improve their surgical skills, they should never hesitate to go back to wet lab and do the same. All this exercise which has been documented so far imparts a right attitude at the beginning of the training, emphasizing that the patient needs and their care comes first before their training. Once this is done, after 4 to 6 weeks, I sit one-on-one with the resident with this questionnaire on various aspects covering for both SICS and phaco. So this encourages them to think on the various aspects of cataract surgery and learn and prepare themselves. In the end, it gives me 2 inputs, whether the minimum requirements of the training is fulfilled or not, if any learning objective is not accomplished, to set a learning plan and work towards it. All this acts as a collection of documentation of evidence that learning has taken place, depending upon which I can decide when a surgeon is starting his or her first case. Once they start operating, they document the stepwise analysis, visual outcome, complication rate, and also the surgical audit. In the stepwise analysis, they document for an individual case what are the steps done by them with help or independently or not done at all. How is this going to help us? It shows them their own learning curve by scrutinizing their own cases. So it serves as a good guideline and prevents them from falling back. It compares themselves with themselves over time, and with a constant feedback, they are going to show improvement in the future. This gives a complete picture of the learning accomplishment and encourages a self-directed learning. I encourage all my residents to make a bookmark in the electronic medical record so that a patient comes, they will be directed to them directly. So they'll be seeing the patients. So doing this post-op follow-up and tracking the outcomes helps them in many ways. One, it tells them how well they are performing, and it tells what is the level of trauma or inflammation they are caused in the eye. And third, understand about the surgically induced astigmatism and also know about the biometry and IOL per calculation. They also enter the complication rate month-wise. When faced with a complication, always as a trainer, our role is to give a constructive feedback, what went wrong and what they could have done differently. They also record their cases and do a surgical audit. Depending upon, for every step, they note the time and areas of improvement. This exercise encourages them to know what are the best part of the surgeries, what are the areas they need improvement, and also enhance their critical thinking aspect and hence their surgical performance. They document the same here. So the quality and the nature of exercise, whatever I have described, is the same thing that they're going to carry into their future career. So getting this habit very early part of the training is really essential. And they also know to keep a data and do an audit. All of this has implication in their professional career. Though all of us agree, and many students also agree that logbooks are useful in their training, few don't. This is because logbook always are flawed because of 2 reasons. One, if the structure is not adequate, where it acts only as a burden of data entry, so they're not going to do it. They're going to just fill it because it is mandatory and not just because it is useful for their learning. And again, if it is not mentored and monitored, it's going to be incomplete. So our role as a trainer is to identify their mistake, give a quality feedback, and help them climb the steep learning curve very easily to become the surgeon of highest type. So to conclude, logbooks improve the structure of training and helps the students demonstrate a learning progress and accomplishment of the learning objective. Thank you.
Thank you,
Sorry
Dr.
for the
Samir,
delay, and thank you.
for a comprehensive coverage.
See, always the detailed logbook is very impressive. Very step-by-step logbook, something which is very unique and very impressive. Thank you.
I have a question for the expert panel. Regarding other specialities like glaucoma or this thing, do you review the fellows' cataract logbook before you take them in for glaucoma, or how do you go about it?
No, it's integral at our thing. So all our glaucoma senior residents, rather than fellows, whatever, they have to do cataract surgery with us anyway.
So it's an integrated logbook, glaucoma and cataract.
Yes, because usually they are in the specialty, and as Dr. Sirisha said, the first 6 months are actually attuned towards more cataract surgery even when they come fresh out of their post-graduation. So invariably they do their cataracts and then gradually go into the glaucoma training. So no, we don't.
But
we
the
don't
log,
insist.
yeah, rightly sir. The logbook gives a very good indication of the standard of the surgeon. So the quality of the surgeon to a certain extent, we know by going through the logbook in detail, find out exactly what are the results, what are the complications, what steps, what is the level of the surgeon. So you can take it from a different tangent if the person is little better. So I think logbook is a very good indicator for that.
For refractive surgery also you have a separate
Yes,
logbook?
yes, we have got refractive, we got everything.
For a separate
logbooks for everything.